Hello, everyone, and welcome. Before we begin, I'd like to take a moment to respectfully acknowledge the traditional and ceded and unceded territories of the Indigenous peoples across Turtle Island, in the land that the colonizing peoples now call Canada. We are deeply grateful to live, work, and learn on these lands, which have been cared for by Indigenous peoples for thousands of years. We honor the lasting connection between Indigenous peoples and their traditional territories. We recognize the importance of learning from, respecting, and amplifying the histories, cultures, and contributions of all Indigenous people. And we humbly acknowledge the need to work towards restoring meaningful, honorable relationships with them, which includes advocating for the co-creation of culturally safe healthcare systems, the closing of any health gaps between Indigenous and non-Indigenous peoples, and the embedding of Indigenous wellness into all aspects of kidney healthcare. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, awareness and advocacy, and education and support. Our topic this morning is about the drug Jinarc, or Tolvaptan is its generic name, and it's used for ADPKD. There will be time to answer questions at the end of the formal presentation, so feel free to leave your questions either in the Q&A area or in the chat throughout the presentation, and we'll try to address your questions. This webinar is being recorded and will be available to view on our YouTube channel in the coming weeks. I'll now introduce our panelists for today. Dr. Avinash Rao is an accomplished nephrologist and internist serving the Nova Scotia community with extensive experience in general nephrology, onco-nephrology, kidney transplantation, and dialysis care. He's a recognized educator and recipient of the Specialist Preceptor of the Year Award 2025, actively mentoring residents at Dalhousie University. With a strong academic and clinical background, including a fellowship training at the University of Toronto and certification from India, Dr. Rao combines technical expertise with patient-centered care. He has contributed to multiple peer-reviewed publications, presented at international conferences, and is actively engaged in community health initiatives. Dr. Rao emphasizes compassionate, evidence-based care, lifelong learning, and mentorship, while leading efforts to improve nephrology services across inpatient, outpatient, and dialysis settings. And we also have a patient partner today, Erika Williams. She was diagnosed with ADPKD when she was 13 years old. She was on Tolvaptan for 16 years, hemodialysis for 1.5 years, and recently, on May 17th, 2025, she received a kidney transplant. Erika is a strong supporter of both the PKD Foundation of Canada and the Kidney Foundation of Canada. She received an award from the Kidney Foundation on September 18th, 2025 for her lasting, dedicated involvement and heartfelt commitment to the kidney community of Nova Scotia. She's a strong advocate for remaining as healthy as possible, having the best quality of life as possible, and staying mentally and physically fit while living with PKD. Welcome to both of you, Dr. Rao and Erika. And we're going to start this morning with Dr. Rao's presentation. He will be talking about the drug Jinarc, or Tolvaptan. And Dr. Rao, if you'd like to put up your slides now and we can get started.
Are you able to see my slide there?
Yes.
Yeah. Okay, great. Welcome everybody to today's session, and thanks Michelle for introducing me to the group. So as already said, so we are going to discuss the medication, the only FDA approved medication at this point for treating the PKD, Tolvaptan, and my thoughts and my experience around the medication, which is used in some of my patients who have PKD. So before I begin, I just want to let everybody know that this is not a teaching session. This is a discussion forum. So if you have any questions at any point of time, just post it in the Q&A section, And in the interval, I'll be taking some of the questions as well. So I'll be happy to discuss any more questions other than which were posted before this session. So I have included most of the information in my slides as much as I could. And if there are any other questions, I'm happy to take them as well. So I do not have any conflicts of interest. I don't have any associations with any of the drug companies, no sponsors for this talk. I'm not promoting or advertising any of the medications. So most of the slides and most of the information is on the generic medication Tolvaptan. I might be using Jinarc once in a while because that's the most common medication that or the drug form that we use, but it's mostly Tolvaptan, the generic one that we are discussing today. So the information on PKD is not new for anyone here. So you have heard many talks before. You have experienced many of these symptoms yourselves, and you have been on the medication Tolvaptan as well. So I just for completion reasons, I have included some of the slides on PKD itself. So the current prevalence that is estimated in Canada regarding the PKD itself is around 35,000 patients, Canadian patients have PKD, and this is as per 2016 report, and there might be more patients at this point of time. So as per the US studies, it is one of the fourth leading cause for causing end-stage kidney disease or advanced kidney failure requiring dialysis. And 1 in 10 patients who have PKD progress to end-stage kidney disease. And just for the knowledge purpose, only 50% of the patients who have PKD, they come to light for diagnosis, but otherwise 50%, other 50%, they may not know the diagnosis even till their end of life. So it's kind of a very silent disease. It's only known when it is manifesting with symptoms, or otherwise if somebody is diagnosed for any other reason. For example, if somebody undergoes imaging for any other reason, if the disease is picked up, that's how it comes to light, but otherwise it may be silent for throughout the life. So usually the diagnosis of PKD happens in second or third decade mostly, and that is why it's kind of autosomal dominant or adult onset disease. And mostly the mutations with some of these genes, especially PKD1 and PKD2, these are the most commonly found genes when they do a genetic analysis to find out the exact reason. So basically, these genes code for some of the proteins which are involved in the signaling pathways in the kidney, leading on to the cystic kidney disease. So when it comes to advanced kidney failure stage, mostly the PKD1 is the gene which contributes to most of the patients in stage kidney failure, and we see patients ending up on dialysis at the age of 50-55 years when it is PKD1 mutation. In the cases of PKD2, it's mostly benign, and if at all somebody ends up on dialysis, it would be at the age of 70 to 80s. So there are other genes as well which have been contributing to the cystic kidney disease as mentioned here, but they are mostly milder variants, and they present with variable manifestations. And we have no many patients with these gene mutations ending up on dialysis. So the investigations are still ongoing, and we might have more knowledge in the near future. So you may know this, but not everybody gets genetic testing done because it's not often required. The genetic testing is done only in cases wherein we have confusion with the diagnosis, when there is a different variety of manifestation. For example, if there is a manifestation in younger age groups with cystic kidney disease, or if there is no family history, or if there is any variation in the kidney sizes, in those cases we opt for genetic testing to see if there is any new gene, or if there is any new component that contributes to the polycystic kidney disease. But otherwise, it's mostly the diagnosis is mostly based on the clinical symptoms, enlarged kidney with cysts, which is found on the imaging otherwise, and as well as the strong family history, as most of the patients with PKD have. So if there is a question on how what lab tests are done to diagnose, so there is no exact lab test that can pick up the polycystic kidney disease. It's mostly the creatinine based tests, which are the creatinine is basically elevated at the later stages of disease. It's not the initial manifestation. So the initial manifestation is the enlargement in the kidney size or the enlargement in the cyst size, which contributes to the kidney dysfunction. So only in the later stages we see that there is a manifestation of increase in creatinine or reduction in the EGFR numbers, which cause trouble with the overall kidney function. And these are the indicators to kind of monitor further and evaluate or manage at a later stage. So this is a excerpt from the recent KDIGO guidelines. So KDIGO is the International Society for Nephrology, which gives us recommendations on various kidney diseases. From the recent guidelines, I picked up this, saying that they recommend ultrasound as the first line imaging for picking up the diagnosis of polycystic kidney disease. And this is in the context of family history, kidney function abnormality, or comorbidities that the patient have. So some of the patients usually ask me why I'm not doing MRI at an initial stage. That's because that MRIs or the CT scan is recommended only after an ultrasound diagnosis is made. So some of the practitioners also say that they consider MRI as an initial modality other than ultrasound. That's because if there is a younger onset, or if there is any if there is any query on kidney donors or whatnot, in such cases MRI would be more beneficial. But overall, the initial choice for imaging would be an ultrasound. So as we all know, there have been multiple impacts of disease on our quality as well as quantity of life. So impact of disease can happen both physically and mentally. And physical manifestations of the disease could be with fatigue, abdominal or back pain because of the increased kidney size, abdominal distension, again with the increasing cyst size, blood in the urine if there is any rupture of the cysts, urinary tract infection because there is a accumulation of the fluid within the cyst which predispose for the infection, kidney stones because there is stasis of the fluid and there is no much of a calcium or the uric acid excretion from the urine, so that causes kidney stones, high blood pressure, which is one of the earlier manifestations in the disease, brain aneurysms, which can be an extra kidney manifestation especially in patients who have family history of such kind of aneurysms. There could be possible association of cardiac valve disease in 20 to 30% of patients. There could be also manifestations with liver and pancreatic cysts, which are common associations with kidney cystic disease and hernia. So these are the physical manifestations with which usually the patients present. And there could be also, not could be, but usually this is also associated with mental stress, anxiety, depression. There is a social stigma associated with the disease that people feel or patients feel that they're different from the normal population. There is fear of disease in the offsprings. There is always a query on pregnancy and conception and around breastfeeding. And also there is limitations to the daily activities because of the disease. So this is the impact of the disease, which is quite dramatic, and this can compromise people's quality of life. So the current standards of treatment include both non-pharmacological or non-medication and the medication choices. So with the non-pharmacological aspects, as you all know, we contemplate more on hydration point of view, and I'll discuss more about hydration in the coming slides. And salt restriction, especially dietary wise, if you can restrict the salt intake to less than 5 grams a day, then that would be more beneficial. Healthy diet, especially salt restricted diet, and exercise, limiting alcohol, limiting quitting smoking, and self monitoring of the blood pressure. So in the next slide, I would say I will reflect on what are the targets for the blood pressure as well. And in the pharmacological aspect, we have only evidence on two different family of medication. One is ACE inhibitor or ARB, which is a common medication that we use in the hypertension world to treat the blood pressure. And also in one of the previous trials, which was called HALT PKD trial, it has shown to help with the reduction of the growth of the kidney size as well. And the second piece is Tolvaptan, which we are going to discuss today. So just some highlights on the blood pressure goals. If somebody has question around this, and I always get the questions around this. So this is the recent KDIGO guideline from 2025, which have given us a suggestion saying that especially in people with age group between 18 to 49 and who have an earlier stage kidney disease, the target blood pressure for them would be less than or equal to 110/75. So this is as per the home blood pressure monitoring, and this is as well if the patient tolerates it, meaning if some people may have symptoms related to low blood pressure when the blood pressure is less than 110. So it is all individual based, and it's important to target as less as we can. So that is the guideline. And in patients who are above 50 years of age, then the guideline says that we should target the blood pressure of less than 120 if possible, and again as per the patient tolerance. So as we can see there in the recommendation, the first recommendation, it says 1D in the brackets. That means to say that the evidence for the recommendation is very high. So in patients who are younger, in those patients, we have to target the blood pressure as less as we can so that we can preserve the kidney function over a long run. But in the second recommendation, you can see that it is 2C, meaning it's a lower recommendation. So it's individual based, and we should target as low as we can. So these are around the blood pressure goals. So Michelle, if there are any questions till this point of time, I'm happy to take. If not, I'll go forward.
And I think we're good so far, Dr. Rao, if you want to continue.
Okay, great. So just let me know also in case if somebody is unable to hear well, or if they're unable to see the slides well, I'm able to kind of modify things. I'm open to making changes here. So so we'll go for Tolvaptan now. So I just as I said earlier, this is the only FDA approved drug to slow the PKD progression at this stage. And although there are a few other medications and there is research ongoing regarding if anything else can help with reduction in the size of the cysts or the kidney size, we are still investigating. We have no good evidence for any other medication. So the main culprit in progression of the disease is called as arginine vasopressin. This is one of the hormones which is present in every one of us, and this particular hormone controls the water regulation in the system. So basically what it does is that, as you can see in the figure, it's a bit of complicated figure and it's more physiologic, but I'll try to make it as simple as I can. So vasopressin basically activates some of the receptors that are present in the cells of the kidney tissue. So when it does that, it activates some of the factors which can start secreting fluid into the cells of the kidney tissue. So that's how the cyst starts forming, and there is always that if there is continued effect of vasopressin on the cells, there is more and more cysts growing, as well as the size of the cyst increases. So this is the main culprit behind the genesis of these cysts. So what the Tolvaptan does is that it basically goes and fits onto the receptor where the vasopressin acts, so that it cuts off the action of vasopressin, and that's how it stabilizes the size of the cyst, or it will prevent any more fluid secretion into the cyst, so that the cyst doesn't grow. That's how the Tolvaptan basically acts. So how much does the Tolvaptan gets absorbed in the system? So mostly the Tolvaptan is a medication which is taken orally. So when you take 100% of the medication, only 40% is absorbed into the system, and that is sufficient enough to cause the advantage of having this medication on board. And if there is question around the food intake, so this medication is minimally affected by any of the food, and it is not necessary that you have to take as per your the time that you take the food in the morning or in the afternoon. So, and also the half-life of the medication is 12 hours, meaning it acts only for 12 hours. That's the reason why we space the medication in 2 different times in a day. And it's excreted through the stool so that it does not have any side effects on the kidney function itself. So the one other thing that we physicians as well as the patients who take the medication should be aware of is that there are interaction with other medications. The most common medications that we use in our practices, there are medications like ketoconazole, which is used in treating the fungal infections, amiodarone, which is a medication which we commonly use in managing the patients with cardiac disease or heart disease. Grapefruit juice, it can be taken as a recreation, or sometimes it is advised by the physicians for many reasons. Phenytoin is a medication which is used in managing the seizure disorder. So these are the common medications that we use in the practice, and these may affect the dosing or the variability of absorption of tolvaptan. So any medication change in your medication list should be brought up to nephrologist that you're seeing or the internist that you're seeing, and make sure that it has no interaction with tolvaptan, so that we get all the benefit of the medication. So how does tolvaptan help? So this is the most important question to answer. So we all should be aware that tolvaptan does not cure the disease or shrink the kidneys. Mostly it stabilizes the kidney function. It helps in reducing the kidney volume growth, meaning we cannot reduce whatever has happened already. We can just try to stabilize the cyst size or the kidney size as much as we can with using the medication. And in the trials, it has also shown that it reduces protein loss in the urine. So protein loss in the urine means to say that protein loss always depicts the inflammation present in the kidney. It may be because of the vasopressin effect itself, or it might be because of other systemic disease, like if somebody has diabetes along with cystic disease, or hypertension along with cystic disease. These are all the factors which can cause systemic inflammation. So tolvaptan is a medication which has known from the trials and the studies that it reduces the protein loss as well, meaning that it reduces the inflammation in the kidney. So till date, we have almost 22 and more studies which have shown the proven benefit of tolvaptan in patients with polycystic kidney disease. So you may be aware that there were 2 large studies. One was the TEMPO trial. I think Erika, who will be speaking after me, was also a part of this trial. So TEMPO trial and REPRISE trial, these were the 2 largest trials that we have till date, which have shown the best possible benefits of tolvaptan. And I think TEMPO trial was done, and also the REPRISE trial was done by Dr. Vincent Torres. And the TEMPO trial initially was for 3 years, and they did an extended study for 2 more years to reap the benefits and see how tolvaptan helps with reduction or stabilization of the cyst size. So we have some results here from the studies. So from these studies, there was a proven advantage of yearly preservation of EGFR by 1.23 mils in REPRISE trial and 1 mil in TEMPO trial. So what it means to say is that in patients with polycystic kidney disease, when the EGFR or the kidney function starts dropping, the dropping rate may be 3 to 5% every year. So with the using this medication, at least 1 mil they were able to preserve that kind of a kidney function when they used the tolvaptan. And also they saw that there was a mean reduction of 49% of total kidney volume from the baseline to the post-treatment, meaning that in the tolvaptan group, so they compared tolvaptan with a placebo, meaning there is no exact medication, but they give something in the place of tolvaptan. So they had 2 groups. One group took tolvaptan, other group did not take tolvaptan. So when they compared between these 2 groups, there was a reduction, or there was a advantage of there was a growth of the kidney by 2.8% as compared to 5.5% in the placebo, meaning there is a good 50% advantage of taking tolvaptan in stabilizing the kidney growth. So that was the outcome of the trials. And also the tolvaptan also has shown that in many other trials that it delays the need for dialysis or reaching the advanced kidney failure state by 6 to 9 years, which is a good advantage as per the quality of life. And it also increases the life expectancy by 2.5 years. And I feel that that's a good number of years with an advantage of taking this medication. So it has got a quality of life advantage as well as it increases the life expectancy. So that's the reason why it has been approved by FDA, and we have good evidence till date. So not all patients with polycystic kidney disease have to take tolvaptan, or they are not candidates for tolvaptan. So the patients who meet the following criteria only are recommended to take the medication. So typically this medication is recommended in patients who have an EGFR or kidney function of more than 25 mils. And the second criteria is that they should be having any evidence that would say that this patient has a rapidly progressive cystic kidney disease. So we have some of the criteria from the imaging, which we classify as Mayo classes. And these will indicate that this patient's kidney is growing faster and this patient requires some medication to stabilize the size. So that is dealt with the imaging like CT scans or MRIs. And other indicators to say there is a rapidly progressive polycystic kidney disease is that there should be a decline of more than 3 mils of kidney function yearly. And if the patient is less than 55-year-old, and if that particular patient has an EGFR of less than 65, then it is considered to be a rapidly progressive disease. And when we do a kidney length on the imaging, if the size is more than 16.5 centimeters in the age group of less than 50, then these patients are eligible to have the medication. And we do something called as a pro-PKD score. This is based on multiple factors like gender, genetics, hypertension diagnosed at an younger age, kidney stones at an younger age. So these are the factors which we include in the pro-PKD score. And it is not done in everyone because we cannot get genetic analysis done in everyone. So that's one of the other criteria to say whether a patient is eligible to get tolvaptan or not. So these are all these criteria for somebody to be on tolvaptan. And age-wise, there is a limited data from the trials or studies regarding the efficacy and safety of use of tolvaptan in patients who are more than 55 years of age. So we don't start anybody who is above 55 on tolvaptan. If somebody is already on tolvaptan before the age of 55, we continue the medication, but we never start a patient above 55 years on tolvaptan because we don't have sufficient evidence. So there are some absolute contraindications in using the tolvaptan. So most important one is that significant liver disease, because in the trials, it has been known that at least 4 to 5% of the patients, especially in TEMPO trial, as well as the REPRISE trial, they had liver-related side effects. So if anybody has a significant liver disease already, except for polycystic liver disease, they are excluded from using the tolvaptan. And other contraindications are inability to sense or respond to thirst. Some of the elderly individuals, we don't usually use in more than 55 years old. But in any case, if patient has no sense of thirst or unable to sense the thirst, in such cases, we don't use tolvaptan. In patients with high sodium levels, we don't use tolvaptan unless the sodium is corrected. That's because in the trials, it has shown to elevate the sodium levels. And volume depleted states like severe illness, or for example, if somebody has vomiting, loose stools, high grade fever, sickness which is inhibiting people from food intake or water intake, and in cases wherein people are requiring general anesthesia for any reason, we either hold the pill if they are on that already, or we don't start them at that point of time. And in patients who have uncorrected urine flow obstruction, because as you know, this medication has aquaretic effect, meaning it makes people to pee more water in the urine. If somebody has a urine flow obstruction, we cannot use this medication. When planning pregnancy, during pregnancy, and after pregnancy, when patients are breastfeeding, we don't usually use this medication. If they're already on that, we try to hold it at least 1 month before planning for conception. and we continue to hold it till patients finish the breastfeeding stage. And the last absolute contraindication is concurrent therapy with other medications that we discussed earlier. So because that it may increase the liver toxicity of the medication. So that's the reason why we don't use this medication along with other drugs which can cause problems with the liver. There are also some relative contraindications. So we don't have sufficient evidence to start the medication in somebody whose kidney function is less than 25 eGFR. That's because these patients were excluded from the trials. So that's the reason we don't start. But some physicians may consider starting at an eGFR of 20-25 sometimes, but it's kind of a relative contraindication, and it differs from physician to physician practice. And if there is a history of gout, this is one of the other relative contraindication, because when there is a dehydration, there is a fluctuation in the uric acid levels, which is the prime component of gout. So in such patients who are prone to have more gout attacks or gout flares, we don't usually start the medication unless we can start it, but we have to keep monitoring and keep a close eye on the gout flares. And the third relative contraindication is urinary incontinence, because as you know, once we start the medication, it causes a lot of urinary problems, frequency, and more of urine output. So it may cause trouble to patients who are already having urinary incontinence. So that is one other relative contraindication. So coming to the dosing and titration, the patients who are already on Tolvaptan at this point of time, and people in the group who are already using this medication know that we usually start the medication at a lower dose, and this is how the trials were designed. So preferred starting dose would be 45 milligrams in the morning and 15 milligrams after 8 hours, and we usually advise people to take before 4 p.m. as much as they can, so that the effect of the medication reduces when they go to sleep, so that they don't have to get up often to urinate. So we up titrate the medication every 4 weeks, and the maximum dose that we reach is 90 milligrams in the morning and 45 milligrams in the afternoon. So I think there was a question from the group that I saw before the presentation. So the question was whether everybody should be on 90 milligrams and 45 milligrams, whether the lower dose would benefit or not. So even with the lower dose, there is a benefit, but the maximum benefit is achieved only when we maximize the dose to 90 milligrams and 45 milligrams. Lower doses do give benefits, but not as much as the maximized dose. So that's the reason we contemplate on up titrating the dose as much as we can to give the best benefit of the pill. So the other thing that we can monitor to see the effect of the medication is urine osmolality. Some of your physicians or nephrologists, they might be monitoring your urine osmolality level every time you do the test, lab test. That is to see whether the medication is causing enough water excretion in the urine so that the effect of the medication is achieved. So that's the reason why some of you may be doing urine osmolality test, but it's not always that every physician prefers it, but some of them do it. And when we start the medication, we always expect a decline of around 3 to 9% of kidney function. That's because of the dehydration effect that is through the medication, and it's kind of a reversible. When you stop the medication, the eGFR bounces back by 3 to 9% as well. So it's a temporizing effect. It should not cause any permanent damage to kidney, if that is a question in anybody's mind. Okay. So coming to common side effects, so there are multiple side effects, as we all know. The most important one is the thirst, and this is from the trial results that we have. How many percentage of people have these side effects? So thirst is present in 4 to 55% of the patients, meaning 1 in 2 may have increased thirst. Polyuria, which is increased urination in 5 to 38% of the patient who use them. Nocturia, meaning often getting up in the night for peeing, 5 to 29%. polydipsia, using, having to use more water, and it is advisable as well to hydrate yourself well when you're in this spell. And the thirst increases and it causes more of water intake in 2 to 10%. Gout attacks 3 to 5%, and it has been kind of seen in the trials as well. That's because of the uric acid level fluctuation. Hypernatremia, meaning high sodium levels, in 1 to 4%. That's the reason why we don't start patients who are already having high sodium levels on tolvaptan. And once we manage the sodium levels, they are good to go. And increased liver enzymes, because of any reason, it can happen in 1 to 6%. And hyperkalemia, that's a very uncommon side effect, but it means to say that potassium can increase in few people, and we usually keep an eye on the potassium level when we do the lab test. And I don't say this is a side effect, but this is the problem of using this medication, which is the cost. And the cost is always primary for every one of us, and this is a very costly medication. So for a pack of 14 tablets, it costs around 850 to $900, which is quite high. So that's the reason, why we kind of opt for medication insurances and everything before we start the medication. Are there any questions till now, Michelle, from the group that I can answer?
We have had actually four questions so far. So one person is asking or saying she's drug sensitive and wondering if tolvaptan would be hard to take, knowing that she tends to be sensitive to drugs. And so that's her first question.
Sure. So if you're sensitive to drug, it's hard to say whether you would tolerate tolvaptan or not. If you are a candidate as suggested by your nephrologist, then I would say give it a go, because it's not always that one drug sensitivity means to say that you have sensitivity to all the other medications. Because of the good effects and the beneficial effects of tolvaptan, if you're able to take at least a smaller dose, any benefit, that would be the best. So I would suggest giving it a go.
That same person's always asking about a particular drug, asking if spironolactone might be better than a basic water pill.
So that's a good question. Spironolactone is one of the diuretics, meaning it has this similar effect of some of the water pills that we use commonly, like Lasix or furosemide that we call. So it's the same family of medication, but we don't have any evidence till date that spironolactone helps in patients with polycystic kidney disease, either for reducing the cyst size or the kidney size. So the current evidence only says that the tolvaptan is the medication to go for reducing the growth of the cysts or reducing the growth of the kidney volume. And other medication that I mentioned earlier, the ACE inhibitor or ARBs, these are the group of medications that we usually use to control the blood pressure, and also have shown a good effect in reducing the inflammation in the kidney. So no other medication till date has shown any benefit, although there are trials ongoing. If we get more results on them, we would be able to share, but till date we don't have sufficient evidence on spironolactone for benefits on the PKD.
Someone's asking, would simply increasing water intake to 3 liters per day have the similar effects as the drug tolvaptan? So not taking it, but just drinking 3 liters of water a day.
Yeah, it's a really good question, and probably I'm going to kind of throw some light on that in the future slides as well. But while we're here, I just want to give some information on water intake. So water, basically what it does is that it has the similar kind of effect of tolvaptan, because it reduces the effect of vasopressin on the kidney cells. So before the tolvaptan was found, or whether it was kind of used, it was always suggested that drink enough water. That's because to reduce the effect of vasopressin. And there was also a problem in the trials, especially in the tempo trials, they actually said that they were unable to determine whether it was there any contribution from water intake as well, along with using tolvaptan, that made kidney size stabilize or prevented it from growing. So that's the reason. That's one other reason we have to pick and choose the patients when we start using the tolvaptan, because that's how the trials also showed, because they didn't have enough evidence to differentiate the water effect versus the tolvaptan effect. But anyhow, when they used tolvaptan and placebo in different arms, they were able to find that advantage of tolvaptan, and that's why it is recommended. So even being on tolvaptan, I would suggest, even the guidelines, which I will be showing you later, the recent KDIGO guidelines have also said that at least 2 to 3 liters of water every day is important in somebody who is able to take it, because it has that good effect on reducing the vasopressin levels and also reducing the rate of kidney growth.
Okay. Someone's asking, are there any studies that talk about what happens to your kidney growth after you stop taking tolvaptan? So you've been taking tolvaptan for a while, you stop.
Yeah. So again, I'm showing that slide as well in the coming up slides. So
Okay.
yeah, I'll discuss when the slide comes.
Okay.
So I have the answer for that question already.
Yeah. And I think most of the other ones would also be for later. So why don't you continue now, and then we can address the questions again.
Great. Okay. Yeah, thanks for all the questions. I appreciate it. Great. So coming to the liver toxicity, I think there were some questions around this piece as well. So as we all know, there is a program, if you're on Jinarc or SEMSCA, they have a program of monitoring the liver toxicity when somebody starts tolvaptan. So basically, in this program, there is a nurse coordinator or a nurse who will be reaching out to patients once they kind of start the medication. And every monthly, you have to do some liver function tests. And usually it happens so that when we initiate the medication, after two weeks and 4 weeks, you get a call to do some lab tests. And also after that, every month you have to do the lab test for the liver to make sure that the liver function is stable. This continues for 18 months. And after 18 months, every 3 monthly, you get a lab test to be done before you continue the medication. So this was the protocol which was developed in the TEMPO trial as well, and it was continued in the REPRISE trial. So the basic idea of doing this is that within 18 months of time, there is a higher risk of having liver problem. So once the 18-month period is done, it is seen that after this period, the chances of having a liver toxicity is quite less. So that's why we increase the duration to every 3 monthly, not monthly after that. So again, this is done to detect any early signs of liver injury. And when we start the medication, we always ask the patients to register for this program. And this is, if you're taking Jinarc, it is through the program. When we kind of start somebody on tolvaptan, we fill a form, and that gets automatically registered to this program. And that's how you get calls and monitored monthly from then on. So once you're on this program, there are specialty clinics and in the pharmacies which dispense the medication based on the liver function test. So the basic idea of doing the liver function test is that if the liver function tests are abnormal, and if the numbers are 2 times above the normal level, then it is an indication to stop or hold the medication for a while. At least we have to hold this for 2 to 3 days, and we have to repeat the liver function test. If they are recovering or if they are normalizing, then we reinitiate the medication with more frequent monitoring, for example, every 2 weeks instead of a month. And if there is really a bigger injury, or if there is a drastic change in liver function, and the liver function tests show that the injury is more than 3 times the normal, then we completely stop the medication, and we usually do not reinitiate it. That's because if we reinitiate, the chances of having more liver injury is common, and some of the patients have liver toxicity because of that. and it may lead on to permanent liver damage. So regarding the duration of treatment, so for the duration, there is no kidney function cutoff. So once the patient starts the medication, as we already discussed, we start the medication when the kidney function is above 25. And once patient is already on the medication, we don't usually stop the medication unless if there is a progression to advanced kidney failure, meaning we cannot stop the progress of the medication. Although we can control the rate, we cannot stop the process of getting to an advanced kidney failure. It's not that everybody gets to advanced kidney failure. We try to delay the process as much as we can, but some of the patients, even being on Tolvaptan, they progress to advanced kidney failure. So my practice is that if somebody's EGFR is between 15 to 20, I usually stop the medication. That's because if there is one more problem, if there is one more episode of dehydration or acute kidney injury because of any reason, the chances of having need for dialysis would be much higher in this context. So my practice is to stop Tolvaptan when the EGFR is between 15 to 20, but some of the physicians continue even at the advanced kidney failure state. So we have to discontinue this pill when the patients are on dialysis or when the patients get kidney transplant, but there is no good recommendation at this point when to stop the medication. So what if I stop the Tolvaptan in between? So there are no there are few studies which showed that especially this has been seen in the Tempo 3-4 and 4-4 trials as well, wherein some of the patients had to stop medication because of the side effects. So there were 23% of the patients who had to discontinue the medication in Tempo trial because of various problems like increasing thirst, having to use the washroom frequently, gout reasons, and many other reasons. So 23% of the patients had to come out of the trial because of all these reasons. And it was observed that although the benefits of the medication do not continue after stopping, but whatever they have accumulated as a benefit while on the treatment, that's an advantage. Meaning if the medication has helped at least for 3 to 4 years, whatever the period the patient is on, it has caused this effect in delaying the progression of the disease. But once they stop the medication, the natural course again steps in. So it is not that once you take for 3 to 4 years and you stop it, the medication effect doesn't progress. Like it's done for that. So the natural course of the disease recurs once the patient stops Tolvaptan. And there is no rebound or worsening effect, meaning there are some medications, especially in the blood pressure world, wherein if we stop the medication for any reason, the blood pressure increases suddenly. So this doesn't happen with the medication. You are safe to discontinue. There is no need for tapering, meaning if you're on 90 milligrams, you need not come to 45 and then stop it. You can just stop the medication once for all if that is the case. And yeah, so there is no effect continued after stopping the medication, but whatever benefit that has been accommodated while being on the treatment, that is the advantage that you get while on the treatment. So, so these are some of the questions you might ask your nephrologist before or when you are diagnosed with a polycystic kidney disease. So you could potentially ask if you are a candidate for considering the medication given its benefits. Again, as I mentioned earlier, not all patients are candidates for medication, and there is always a side effect profile of any medication that you take. So you should be very considerate when you kind of consider the medication on board. And it's always good to ask your nephrologist whether you would be a eligible candidate to consider this medication on board. And how will the safety of the medication be monitored? So as we discussed earlier, there are programs which monitor the liver functions, and all the nephrologists who are well versed in treating the polycystic kidney disease are well aware of what are the side effects and how it should be monitored. And how will this affect my lifestyle? So I'll come to this part a bit later because I have some slides how we can manage around our lifestyle as well. So we'll keep this question to the later slide. Other common eligibility questions that I get from my patients are, genetic testing. Genetic testing is not always required. There are some conditions, and some of my patients have had genetic testing for the reasons being it's kind of, when the patients don't have sufficient evidence on the imaging, there is a query whether they have it or not. In patients who have no family history, or if there is any asymmetrical size issue with the kidneys. So in that cases, I order genetic testing, but not in all the cases. And it's not necessary always. And other medications, we have already discussed some of the medications which can interact with tolvaptan. And also, there are no other supportive medications other than tolvaptan to reduce the or stabilize the kidney size. And for the special populations, like in cases of pregnancy and whatnot, we are going to have that slide again in the upcoming slides here. Any questions, Michelle?
Why don't you keep going through the end of your presentation? There are some questions, but I think we can save them to the end.
Sure. Coming to public coverage of the medication in Atlantic Canada. So as we discussed already, the annual cost of the medication is very high. It's $20,000 to $30,000, which is quite high, and it's difficult to afford, especially if there are financial concerns or if there is no private coverage. So at this point of time in Nova Scotia, this medication is not listed in the formulary. It's been kind of, covered by the pharmacare based on some of the factors like low income, receiving assistance or claims of social programs. In those cases, pharmacare coverage is possible, but not otherwise. And it's individual based and depending upon their income and special access. So these factors need to be taken into account before we get an approval. And out-of-pocket costs in such kind of a coverage from pharmacare is around $5 per prescription. That's a copay. In New Brunswick, it's kind of the co-payments are typically 30% per prescription. So it amounts to around $4 per adults and $2 in children. And in children, it's not children, meaning we use only in the patients who are above 18 years, who are again adults. But in case somebody is using for other reasons, then $2 are covered. $2 is the copay that has to be borne. But otherwise, it's still not publicly funded in New Brunswick as well. Same case in Prince Edward Island, it's not covered. Again, it comes to special access and special coverage. It's the same case with Newfoundland and Labrador. So as we know, the Jinarc program, which is from the Otsuka company, they have support program available, and many of my patients reap that benefit from the program. And even the private drug plans, including Blue Cross, covers for tolvaptan. So I usually ask the patients, whether they have the private drug insurance or whatnot before I start the medication, so that they should not discontinue once they are on board. So some of the things that needs to be known by everyone who is on tolvaptan. So when we initiate the medication, we always aim to initiate on a weekend. That's because you have good 2 days or 3 days to cope up with the medications and also the side effects. So it's usually recommended to start on a weekend. Sick day protocol. This is something that I usually advise my patients who are on some of the medications, including tolvaptan, to avoid or hold the medication when you are sick, meaning if you're unable to eat and drink well, if you have a flu-like illness, again, if you have a lot of vomiting, diarrhea, in such cases, you become already dehydrated. So taking pill again on the top of the sickness, that causes more dehydration, and that will lead on to more kidney injury and causing more kidney trouble. So it's necessary that we all know that we have to hold this medication for a few days when we are sick and restart once we are back to our routine. So that's important to know. And drug holidays, meaning if you are planning for a long travel and if you're unable to use the washroom frequently, I think it's reasonable that we hold the medication until we reach the destination or once we are kind of comfortable starting it. So that's one other thing to kind of and holding the medication for a few days will not make a big difference to your overall benefits. So it's only when we hold it or stop it for a long term, then only the medication's effect will wean off. But otherwise, for a few days, you can definitely keep it on hold. Regular follow-ups with nephrologist is important. This is in the perspective of monitoring the kidney function, keeping an eye on the liver function, as well as, when you have somebody to suggest and advise you often, that's how we become more adherent to the medication. So regular follow-ups with nephrologist is important. Around pregnancy planning, so as I mentioned earlier, we have to stop the medication when planning or attempting the conception. It's not that we have to stop when there is conception already, because in the trials and the animal studies, it has been shown that this medication has a teratogenic effect on the fetus. It especially causes fetal dehydration. That's the most important side effect when we use this in pregnancy. So this is based on the animal studies. We don't have human studies on this, but whatever we are knowing from the animal studies, it's best to stop the medication when planning or attempting conception. So we usually avoid the medication in breastfeeding as well, because we don't have sufficient evidence whether this medication gets through the breast milk into the baby. So we usually avoid the medication during the breastfeeding as well. And we should also know that we have to use a reliable contraception method at least for a month after stopping the medication before attempting the conception, because again, having a conception while the medication effect is still on board, that may cause teratogenic effect. So we should remember to discuss with the nephrologist before planning or attempting conception, and also kind of know to use a reliable contraceptive method at least for a month after stopping the medication as well, to avoid any further damage to the fetus. So and also early dietitian referral, in case if you have not met a dietitian till now, whoever is on Tolvaptan, it's reasonable that you ask your nephrologist to refer you to one. That's because you can plan around your diet, reducing the salt intake and increasing the fluid intake. These some of the suggestions can be made better by a dietitian rather than a nephrologist. And it's always a time constraint when you go to your nephrologist, that you discuss around your disease, but you may not have sufficient time to discuss around diet. So dietitians would be helpful in that way. And adherence to the medication is very important. I mean, whenever possible, try to continue the medication rather than holding for petty reasons. Again, we discussed this piece, salt intake. The suggestion, even from the guidelines, is that the amount of salt per day should be less than 5 grams a day. That is to reduce the water, excretion effect of the medication. And also by this way, we can reduce the side effect of the medication as well. So I had a few questions through the email as well, and this is a common question that everybody on Tolvaptan asks me. So how much fluid should I drink? So this is the recommendation that I've put here from the KDIGO guidelines, which was published this year. So they say that, and as you can see, the evidence is not so great. It's a 2D evidence, meaning that it's not a trial-based evidence, or it is not a study-based evidence, but is a practice evidence. And most of the nephrologists recommend that you try to take at least 2 to 3 liters of fluid every day, especially in patients whose kidney function is more than eGFR of more than 30. So that is again because the water has its own good benefits in reducing the vasopressin effect, and that way it reduces the cyst growth. So impact on lifestyle and occupation. So I think when you are on the program with Jinarc, I have always understood that the nurses or the nurse coordinators are very helpful. They usually plan around how you can manage your medication when you are, busy with your work or around the lifestyle. For example, when you have a, holiday or a long travel. So how to adjust the medications. Usually they are pretty good in advising that, and we have gone over some of those aspects in the previous slides as well. And if you are consuming alcohol anytime, or occasionally or socially, it's always possible that we consume alcohol once in a while. So in such scenarios, it's you don't have to be too much worried. So it's only important that you hydrate very often, and you hydrate more than what is usual, because alcohol causes more dehydration, especially with beer. It causes too much of dehydration. So hydrate yourself as much as you can when you consume alcohol. And even with the lunch or the dinner, you can make some changes. For example, if you can have larger meal during the lunch and have a lighter meal during the evening, that will reduce the need for urination in the night, because when you consume food, it causes more solute load on the system. It causes more peeing. So if you can adjust your amount of food intake during the day, that will also help reduce the side effect of the medication. So when you go to bed, it's good that if you can have ample of water at the bedside. It will reduce your movement to your kitchen or the area where you keep your water spot less, and then it'll help you kind of get to your sleep faster. So it's advisable that you keep ample of water at bedside when you go to bed. And when you get up for peeing, then just make sure that you don't turn on the lights. Look at the watch, and we are always prone to looking at our mobile phones, and it's with me as well. So it's very reasonable that we avoid watching watching mobile or seeing the watch for time. That's because it'll help going back to sleep sooner, and it'll avoid any sleep disturbances. And it's reasonable that when you go to workplace, or when you go to theaters for a movie or a concerts or shows, if you can carry a letter from your nephrologist saying that you have this particular polycystic kidney disease, and this letter, sometimes it's difficult to express to everyone that you have this condition, and you cannot always explain to everyone. Sometimes there could be social stigmas around, or you may be feeling a bit of a hesitancy when you explain it to others, and they may not know what is the condition. So in such cases, I suggest that you carry a letter from the nephrologist explaining the condition, so that everybody who just reads through it, they should be knowing why it is important for you to use the washroom, or on an urgent basis. So in UK, they have a bowel bladder community, wherein they have made a plastic card that says "just can't wait," and this is also available as a digital card, which can be used even in Canada. So it's not only for UK people. The plastic cards are available only for UK people, but the digital version of it is freely available online. So if you want to download this and it can be used as something like an Apple Wallet or Google Wallet. You can just keep it with you, and wherever if you're having urgency or you want to use the washroom on an urgent basis, in the restaurants, in the concerts, and in the shows, you can just show to the people. And it has a very small column which explains why it is important for you to use the washroom, so that they can know on an urgent basis and allow you to use the washroom. Sometimes it's always difficult to use the toilets and washrooms, because again, it's kind of a hesitancy many of us may have. So, and this would help that way. And whenever there is a change in the medication, for example, any antibiotic for infection, or if you want to use any herbal supplements, planning around surgery, general anesthesia, it's better to talk to your nephrologist first, because we usually make some recommendation on adjusting the dose of tolvaptan, or holding the tolvaptan for a few days. And also, if there is any interaction between different medications, we usually advise what should be done in such cases, what dose adjustment should be done. So just consult your nephrologist before you make any changes to your health management, be it a medication change or a surgery. So some of the questions I may not have covered in my slides. These were the questions posed before I started the talk. So one of the question was, is there any age limit for using Tolvaptan? The age limit, there is no age limit. So before 55, if you start, then you can continue after 55 for how many number of years for the advantage of the medication. So there is no age limit other than the initial stage. So second question was, are there any alternatives if Tolvaptan is not an option? There is no alternative for Tolvaptan. It's the only FDA approved medication to reduce the growth of the kidney size or reduce the growth of the cyst size. And impact of Tolvaptan on kidney function decline and optimizing the dose. So as we already discussed, Tolvaptan reduces the decline of EGFR by 30 to 40% over many years. And for the best effect, the suggested dose is 90 in the morning and 30 in the evening. So if it's not tolerated, then we can dose reduce, and whatever dose the patient tolerates, we keep them on the same dose. Fourth one was, should you resume Jinarc after liver enzyme elevation and rapid kidney enlargement? So as we discussed earlier, we have systems to monitor the liver enzymes. And I have to tell you that the liver dysfunction happens in an idiosyncratic manner, meaning this side effect is not dose dependent. It is basically that the medication, even if you are on this medication for many years, it can cause drastic increase in liver function tests. So it is not based on the dosing. You need not have to worry that if you go up to 90 milligrams and 30 milligrams, you may get a liver problem. No, it's not the case. It happens in an individual basis. It's not dose dependent. It is not time dependent. So if there is a drastic increase or if there is a drastic reduction in liver functions, then we usually stop the medication overall. We don't re-challenge. That's because we usually try to avoid any more hepatotoxicity or liver toxicity with continued use. So if there is a liver function test elevation by more than 3 times what it should be, then we usually stop it completely. So fifth was, does Tolvaptan help reduce liver cysts? So that's a good question, and it's a very thoughtful question. So effect is mainly on the renal cysts. The trials have shown only mild effect on the liver cyst. There is no considerable reduction on the liver cyst size. So there are some medications which are particularly used in the liver cyst area, but Tolvaptan doesn't have good effect on the reduction of the liver cysts. The last question is, when is Tolvaptan recommended for someone with a family history of PKD? So remember, this medication is not used prophylactically, meaning if a family member at a younger age, even if they have a strong family history, we don't use the Tolvaptan unless they meet the criteria for starting the medication. So it is not used unless it is indicated. So these are some of the trusted resources for information on polycystic kidney disease. So final words, Tolvaptan, it's the first and the only available disease-modifying therapy in the area of polycystic kidney disease. As we know by now that it slows the progression of polycystic kidney disease, but it requires closer monitoring, especially when it comes to liver functions. It's not yet covered from the provinces, but there are access programs to manage the financial part of using the Tolvaptan. And nowadays, in at least in Nova Scotia, we have a generic version of Tolvaptan, and some of my patients already have started using them. And lifestyle adjustments are required, but benefits are significant. So it's always kind of a tricky situation, but it's very reasonable that if people can continue Tolvaptan for the benefit it gives, that would be the best.
Awesome. Yeah. Thank you so much. If you want to stop sharing your screen, then we can see everyone's faces full size.
Oh, sorry. Stop share. Okay.
Awesome. Thank you. Now I notice we've gone over past 11 o'clock, and
I
I
thought I
just
had
wanted
very
to.
minimal slides, but
No, that's okay. I just wanted to check with you, Dr. Rao, if you have a little bit more time. If you need to go, that's okay. All of these questions are very important, and
Sure.
I will make note of them all, and I can send them to you afterwards if you want to add maybe another slide or something, and then send me the presentation.
Okay.
Or we can answer them now. What do you think?
If Erika is okay, then I'm okay.
Yeah, I'm not under time restraint. Thank you.
Okay.
Sure. Okay. Well, why don't we jump in and see? Someone is asking, they've been on Tolvaptan for 10 years and they're 35. Will they be taking Tolvaptan until it's time for them to have a kidney transplant?
Sorry, I didn't catch the first part of it.
They've been on Tolvaptan already for 10 years,
Okay.
and they're only 35, so probably quite some time from kidney failure. So will they be on Tolvaptan until they need, another treatment for kidney
Yes.
failure?
Yeah. So as I mentioned in one of my slides, that there is no age cutoff. So until somebody requires further management with dialysis or transplantation, it's reasonable to continue the medication. In my practice, sometime I stop it once the kidney function is around 15 to 20%. That's because that there is a reversal effect of EGFR, meaning as we saw earlier, Tolvaptan causes 3 to 9% of reduction in EGFR when we initiate it. So to get the advantage back, I usually stop it and delay the need for dialysis. That's my practice, but it's not. And I discuss with the patients so that they are well aware. And yeah, it's recommended that we can still continue the medication till the other advanced kidney failure treatments are on board. So it's fine.
Okay. Will the side effects of Tolvaptan change at all as the kidney function does start to decline? Or will you always have the same side effects that you had at the beginning with Tolvaptan?
Yeah, it's mostly the same side effects, but again, as I discussed earlier, you should be aware of the sick day protocol. If you're sick for any reason, it's reasonable to hold for a few days and get it back on once you are recovering. But most of the side effects usually continue in the same way. So there is no much of a difference. And I've seen all stages of kidney disease patients on Tolvaptan, so there is no much of a change between them.
And they're saying they already drink and pee so much. Does that ever change, or does it just stay constant? You're always going to have to drink a lot and always going to have to pee so much.
So as per the studies, 3 liters of water consumption in a 70 kg individual, it reduces the urine osmolality considerably. So, I mean, I would ballpark the water intake to around, 3 liters or so. I don't usually advise my patients to overwhelm with water because it reduces your appetite as well. So we have to balance out between the fluid intake and your appetite. So, if you can consume around 3.5 liters to the max, that would be the best. 5 to 6 liters or 7 liters. I have patients consuming 7 liters, 8 liters, and I don't usually recommend such amount of fluid.
Okay. I see there's a question here about federal disability tax credit. I'll say to that person, we will try and get an answer for you and let you know after. So we won't to answer that now. Someone says they have PKD and their daughter, who's 16, has been diagnosed. When will they need to think about whether she needs to go on Tolvaptan?
Yeah, good question. So as we saw the criteria, so it's more than 18 years when we consider starting Tolvaptan. So any patient who is diagnosed with PKD with an EGFR of more than 25, And if they are above age of 18 and meeting the rest of the criteria for rapid progression of kidney disease or the growth of the kidney, then in such cases we consider tolvaptan. So 18 years is the cutoff to start.
Someone is asking about the cost of the medication. I will say that I'll answer that question in a follow-up email that I will send out to all the registrants. Then someone's asking, why has my doctor recommended I take 6 liters of water a day when I'm on tolvaptan?
Again, I'm not sure, but I can just quote whatever guidelines we have at this point of time. And as you saw earlier in the slide, the KDIGO guideline, which was very recent, 2025. So they have recommended 2 to 3 liters at least. And they have also said that in case somebody has a kidney stone, in such patients, we aim between 3 to 3.5 liters. And again, the evidence is, there is no evidence on water intake. So the evidence is very poor. And this is what I can quote. But, experience-wise, 2 to 3 liters should be sufficient enough to reduce the urine osmolarity to the level that we want. 6 liters, it would be too much.
Someone is asking in the chat, how often do people have to get up and urinate during the night? That may not be something that you know, but
I mean, it's difficult to answer. It's individual basis. So, yeah.
This person is not on tolvaptan, but they have been drinking 5 or 6 liters of water a day for the last 5 years. What's the benefit of going on tolvaptan if you're already drinking that much water?
So in the trials, there was a strict monitoring of patients on water intake as well as the medication intake. So along with water intake, when they were on tolvaptan, there was a good advantage of 49% reduction in the cyst growth or the kidney size growth. So that means to say that tolvaptan has its own individual good benefit along with continuation of water intake. So that's the reason why we recommend being on tolvaptan along with water intake.
Thank you. And then there's one last question that's come in. Should I continue when I've got elevated SGPT and rapid kidney enlargement in the last 6 months? Should I keep staying on tolvaptan even with those elevations?
So I think this is a question to be asked to your nephrologist or the physician who is following for your PKD, because if they feel that the elevation is not too high, then they probably are keeping an eye and they might follow up on that. If it's really high, as we discussed, if it's more than 3 times the upper limit of the normal, then you should be, they should stop the medication. Or if it's more than 2 times the normal, then still you need to hold it for a few days and restart it once the kidney function, the liver functions recover. So that would be my say to this, but I think it's left to your nephrologist to make that decision.
Awesome. Well, that seems to be it. And I just want to thank you so much for your presentation and for staying a little longer to answer the questions. I know that it's been a big help. And if you need to leave now, that's fine. We'll be having Erika talk about her story, but we really appreciate the time that you've been here, Dr. Rao.
Thanks for the opportunity, and thank you for giving me this platform to share my thoughts.
Right, you're very welcome.
Have a great day.
Take care. Okay, so now we have Erika. And Erika, in terms of your time, if we go a little past 11:30, is that okay, or would you can end it? Okay. We wanted to have a patient here to talk about what it was like for her to be on tolvaptan, and Erika has been on tolvaptan, although as we heard earlier, she's had her transplant now. Congratulations.
Thank you.
Hope everything's going well. Why don't we start by just filling in people about your family history or what you knew, who had PKD, and we know that you found out you had it when you were 13, but how did you learn about PKD, or what was the experience of other people in your family?
Yes. as my mother was diagnosed in her 30s with PKD, so the doctor at that particular time decided we had 3 girls in our family, so my siblings and myself test us, and he did an ultrasound, and I guess he saw some changes already in the kidneys. But it came from my mother's father's side. Now, my grandfather died of kidney disease just before the war. They were from Europe. And we never knew it was PKD, it was just kidney disease. But then out of her, she had 6 in her family. 1, 2, 3, 4 of them had PKD. And both of my siblings had PKD, and a lot of my cousins had PKD. So I kind of grew up with the disease. My mother dialyzed, did her hemodialysis at home. Then it was like a big machine. They converted a laundry room into the area where they would have the machine. Now the hemodialysis is much smaller. My sister did peritoneal at home because she was in Fredericton, New Brunswick. They didn't have hemodialysis there. And my younger sister did hemodialysis for 12 years. So I kind of knew what it looked like to be on dialysis. And my mother had 2 transplants and what transplantation was like. Yeah, so I was familiar with the disease on a basic level. You're never familiar with it really until it happens to you, right? Yeah.
Right. So tell us, you have a kind of unique story of going on Tolvaptan because you went on it while it was still in trials. So tell us a little bit about that.
Yeah, I was one of the original Tempo studies. At the time, my younger sister was on dialysis and they were recruiting for patients for the research study, and she passed my name on, and I just got in there in time because you couldn't be over 50, and I just turned 50. So I had a trip planned, so I did my trip, and when I came back, we started prepping me for the research study. I did an MRI because they had to measure the volume of my kidney. I probably had an ultrasound and a CT scan and some blood work, and then we started. And in those days, I looked at the numbers of recommendations, how to titrate for the Tolvaptan. And in those days, when you were on the research study, you started at a very, very high dose. And then I don't remember them titrating me down much, but I do remember with my nephrologist, Dr. Soroka, who looks after the PKD stuff here in Halifax, I did titrate down because it was a little uncomfortable with that high of a dose, right? So yeah, there were 12 of us that started in that Tempo study. 6 of us continued, half for whatever reasons didn't continue. And I met Dr. Soroka at the kidney walk on the weekend, and he said there's still one woman on Tolvaptan. She hasn't reached kidney failure yet. So yeah, no, but she's considerably younger than me. No.
So tell us, what was it like when you first started taking the Tolvaptan? What did you kind of notice right away, or what kind of things were you shocked or surprised by?
Well, you noticed your thirst right away. So you had to make instant adjustments in making sure that you had a water bottle with you at all times. So I had them all over my car, all over my desk in my office, in all my bags. And to me, you were so thirsty because I was on such a high dose. It didn't matter whether the water was warm or it was cold or what it was, as long as it was water, right? So that was the first thing I noticed was a lot of anxiety about the thirst. If I forgot my water bottle, I had to go into a store and immediately buy water. You just couldn't be without water. The frequent urination, I was already 50. My kidney function was, GFR was already 50%. So I was already urinating fairly frequently. So some nights were worse than others, but I was already getting up at the night to urinate, but that increased a bit. But I would say for me, and everybody's personal, some people, they find the urination harder. I found the thirst harder than the frequent urination, just because you were very, very thirsty. Yeah.
Well, I know we have some patient stories from other people who've been on Tolvaptan, and they talk about there are apps now that can tell them where bathrooms are when they're out and about or traveling. I mean, did you think about things, it sounds like you were working, but was there at any point, did you have to really strategize? Where am I going? Is there going to be a bathroom? Did it ever get to that state?
Yeah. I mean, you learned where all the bathrooms were very quickly. What store had accessible bathrooms, which Sobeys, like very, very interestingly, my pharmacy doesn't have a bathroom, right? So you'd be standing in line for your medication. Sometimes, okay, I have to go to the Sobeys because I can't stand in this line anymore. And traveling, like in Nova Scotia or from Nova Scotia, New Brunswick, like an average person would take maybe 4 hours to get to Fredericton. I knew I would have minimum two stops along the way. So you calculated your time when traveling a little bit. So you had to get used to using public bathrooms. Some were cleaner than others, right? Some were downright terrible, but you just, being a woman, you tried not to sit on the seat and just not think about those kind of things. And I'm also very active, like I'm a cycler, and I learned how to squat behind a tree and just tell my group not to look. But one lifestyle thing that did change, I stopped hiking because I couldn't carry enough water. Whereas on my bicycle, I could carry it in my bike cages and in my pannier and stuff. So that was okay, right? But that was the one big thing. You knew where all the washrooms were and you made sure you always had water with you. Yeah.
And what was it like in terms of testing that they might have been doing for your liver function? I mean, how often?
I just remember the blood work. I don't remember anything extraordinarily. I do have cysts on my liver, and my liver function remained constant. It didn't decline at all during the whole time I was on Tolvaptan.
That's good. So you said that you started at quite a high titration, and if I remember correctly, it didn't change, like it didn't decrease as you were using it?
It may have decreased a bit on the study, because the study, like Dr. Rao said, was 3 years, and then they extended it to 5. And then there was a very brief break in there where there wasn't a doctor that wanted to take on the PKD patients, the Tolvaptan, and then Dr. Soroka stepped up and we continued on it. So then when I had Dr. Soroka, we discussed, that's when we lowered my dose a bit, so I'd be more comfortable with the frequent urination and the thirst, right? Yeah.
And was it something that, in the end, how long did you end up being on Tolvaptan in total?
Well, I started it when I was just 50 years old in the summer, about this time, and my birthday's February. And I stayed right on it till the end. I was only at 7% when I started dialysis, and I was still on the Tolvaptan. And so that was 15 years, a little over 15 years. Did I ever go off of it? No, at the time, I think now there's more flexibility around take the Tolvaptan with lifestyle. At my time, I think there was a lot of, well, please, take your dose twice a day and never miss a dose. That I think the philosophy was more like that in that time. So I rarely missed a dose. If I was sick, yes, because you just didn't feel like taking pills at all, right? So you just didn't, yeah. And the water, I know there's discussion about getting your 2 to 3 liters. I didn't find that an issue. You just wanted to drink all the time, right? So there wasn't an issue with that at all. Yeah. When I went off the Tolvaptan, I was really concerned. I thought, oh my God, what's going to happen to me? I've been on Tolvaptan 15 years. They're going to suddenly take me off of it when I start dialysis. What are my side effects going to be like? Like, what's going to happen? Am I going to start having pain in my cysts? Am I going to start having tons of hematuria? But actually nothing happened. I didn't notice the side effect from going off of it. Yeah.
Awesome. And when you went off it, was that when you started your dialysis?
Yeah,
kind of
I was at 7% by that time. Yeah. So right away, right the day I started dialysis, I was on it till the day I started dialysis.
If you had any tips or insights to share with people who either are on it now or are thinking about going on it, what to you were the big things that either you wished you knew or Yeah.
Well, discuss your dose with your doctor, right? And if you're really uncomfortable on that dose, like you just can't stand your thirst or the frequent urination, discuss that with them, and hopefully they'll adjust that and titrate you down a bit, because that was very, very helpful. I missed doses here and there in the beginning when I was on the study because I wasn't used to taking medication. So especially because I took it in the morning at breakfast and in the evening at supper time. And if I was going out for supper, sometimes I would forget to take it when I got home, right? So plan for those things, put it in a little pill bottle in your purse and take it when you're out. That's helpful. And don't worry too much about the sleepless nights. Some nights are going to be, every hour you just feel like you can't sleep. Other nights you'll have better sleeps. If you can manage your mental health state around it, just try not to get anxious and just relax. I did a lot of mindfulness when I couldn't sleep at night, just, being grateful for having a bed and my soft sheets and all that kind of stuff, and tried not to get anxious about, I have to get up at 6 o'clock to go to work. Oh, this is terrible. I tried not to do any of that. I tried to just be grateful that I was on the medication, and it was, because I had 2 sisters on dialysis at the time, that I'm not on dialysis, and it's really helping me. And also just try not to get anxious about not sleeping, because that doesn't help at all. I know it's hard to say. So the amount of time you sleep, I think, is not only connected with Tolvaptan, it's connected with your mental health state. Are you stressed at work during this time? I mean, I was right in the middle of menopause, so that didn't help either, right? So it's kind of all together, right? I don't think you can just separate it, right? Yeah. And if you're having problems with anxiety about it, I would suggest that you look into methods to reduce your anxiety. Yeah.
And overall, when you look back on it, are you glad that you had the opportunity to start on it, to be part of the research, and then be able to continue on it for so long?
Yeah, I'm grateful. Like what we saw in the studies, Dr. Ross said 6 to 9 years, right? And I was talking to the Atsuka rep at the kidney walk on Saturday. He's thinking now that maybe the people are getting 11 years, right? So, I always told myself with the frequent urination, well, it's better to pee than be on dialysis and not pee, right? And I didn't have very good thoughts about dialysis during that time, because I saw some things with my sister, my mother, and my other sister. And so I really wasn't keen to go on dialysis. And for sure, it's the only thing that we have right now that has some hope in slowing down the progression of your disease and helping you stay off dialysis a little bit longer. And so I looked at it as a very positive thing. Now, my younger sister, because I went on the study, her words were very powerful. She said to me, well, you're already 50, and if it doesn't work for you, maybe doing the study will help people behind you with PKD. And I thought, that's a powerful thing to say, right? So I looked at it that way as well, right?
And I guess one thing we haven't mentioned, but I know from your stories, it was a blind study at the beginning. You weren't supposed to know if you were on the drug or not, but you figured out right away that you were probably on the drug.
Yeah. That's what Dr. Soroka or whoever, was he with me in the beginning? I can't remember the doctor, but it was Susan. I can't remember her last name, the nurse. But she said, we can tell right away, because they're the people that have the water bottle right there, right? They put it on the table when they come in, and they're drinking water constantly. Yeah, and the frequency, the thirst and frequency of urination was evident that I probably wasn't on the placebo, right? So, yeah.
But definitely worth it overall. You wouldn't.
Yeah, the cost. I was lucky. I was working for the government for most of the time I was on Tolvaptan. So they covered 80%, and the rest of it was covered, I think, by Atsuka. I didn't even have a copay, right? Which I do now with my medications. And it was very well managed. It was managed by a pharmacy, first in Amherst, Nova Scotia, then in Dartmouth. And this is what the pill pack looks like, right? And I only had one left. I don't know why. And because I went through my drawers the other day to get rid of all my old medication, which there's tons of, and you just open it up. And this is for 1 week. So they're all in 1 week. And we always make fun that seniors wouldn't be able to use this pack, right? And you can tell right away, it says the AM and the day and the PM and your dose. So it's not easy to mix it up, right? So, and this is for 1 week, and you get a little box. So I assume that it's enough for 3 months. 3 months, yeah. And the pharmacy is great. They call you and say we see that you're due in a week or 2 weeks for your new box. They deliver it to your house, ask you when you're going to be home. Do you want an AM, PM delivery? In the beginning, when I was working, I always had the delivery come to work. If I was traveling, they delivered it to wherever I was, not out of country, but in the Maritimes somewhere. So it was very easy to manage from that perspective. A couple of times, I'd say in the 15 years, I had to do the phone call because I'm thinking, they haven't contacted me. But it was rare that I had to do that. And if there was a snowstorm coming up or something like that, they called me and said, okay, there's a snowstorm coming up. We want an early delivery, right? So they were very cognizant. And also they have a pharmacist. So once I was taking an antibiotic that affected the Tolvaptan, I had a phone call by the end of the day from the Jinarc pharmacist saying, get off of that. We need to get you on a different antibiotic that's not good with the Tolvaptan, right? So.
Awesome. And I'll say to the people watching, we've had a few people have had to leave us, but Otsuka, the company that makes Jinarc, does have a program called Origin where they can offer you wonderful support guiding you through the whole process, and also talking about options in terms of covering the cost for it. So I'll share information about that in a follow-up email, but that's fantastic to hear that they were so on top of things.
Mm-hmm.
So I think unless there's anything else that you wanted to share, Erika, I think that we've...
No, I really encourage you to go on it, because I've been on the 2 other journeys, the dialysis and the and kidney transplant, and they're journeys of their own. And it's way easier to be on Tolvaptan than either of those journeys, right? So
that's a fantastic way to put it. Yes. If anyone has any questions for Erika really quickly, be happy to take any of those. If not, we'll be able to wrap this up then. Really appreciate you being able to be here, Erika, especially just waiting a long time to be able to speak. But
I learned something today too, so there you go.
Oh, awesome. It's really good. We always like to have a patient telling their own story about what it's been like under a certain situation. I see someone saying, thank you for sharing. Would love to hear from you more, maybe about your transplant. Well, maybe we'll have to have a different event where Erika can come and be a patient partner again. Awesome. Well, thank you, everyone. I hope that you've gotten a lot out of this session. It is being recorded, and we will post it on our YouTube channel in the coming weeks. And I just want to thank, again, Dr. Rao, and also thank Erika for being here and being able to answer questions and give context. Thanks so much, Erika.
Thank you. Thank you, Michelle.
Okay. Bye-bye, everyone.
Bye-bye.